All right, so in this lecture, we're going to talk about neurocognitive disorders, dementia versus delirium, things like that. This is a topic that you will see again when we move into Jerry Psych. So I never want you to, learn and dump, but this is a repeated topic throughout the semester, so you'll need it again. So we're just kind of going to talk about neurocognitive disorders, um, who they affect, how they come up, what they look like, what our role is as the nurse, and how we're going to care for them using the nursing process. So there's a couple of different neurocognitive disorders. There's delirium tremens, also known as DTs, um, dementia, and others. And then we need to talk about some of the differences. So DTs, delirium tremens, is a rapid onset of irritability, confusion, tremors, nausea, vomiting, and seizures. And this is typically caused by withdrawal from a substance, most commonly alcohol, but it can be other withdrawals. These can lead to death if there is not any kind of intervention done. Typically, the interventions placed for DTs are going to be benzos, barbiturates, and antipsychotics. So that, let me see if I can semi-nicely write that. Benzo, barbiturate. Sorry. And anti. Mm. Okay. So then we have dementia and major cognitive disorders. They're a wide variety of disorders that impair cognitive function such as memory, social skills, reasoning, and intellectual ability. Okay. So let's talk about the difference between dementia and delirium, because now we know the difference between delirium and DTs. Typically DTs with deadly and caused by substance use. Okay. So delirium. The onset of delirium is going to be very rapid and acute. It can onset within hours, whereas dementia, it's going to be a slow, gradual process. Okay. So the contributing factors, delirium, is typically caused by something within the body, some form of homeostasis being off. So dehydration, hypoglycemia, fever, infection, hypotension, drug reaction, head injury, things like that. Whereas dementia is things like Alzheimer's disease, vascular disease, HIV infection. You can't have TBIs cause it in the long term. Chronic substance use and other neurological disorders. Okay. Your cognition with delirium is impaired memory, judgment, attention, and calculations, whereas with dementia, you're still going to have impaired memory, judgment, attention, calculations, but you're also not going to be able to think abstractly, and you're going to have that agnosia, which is that inability to remember words. One of the big differences is that delirium, you're going to have a decrease level of consciousness, whereas dementia, your level of consciousness is not going to be changed. This is one of your major assessments when determining delirium versus dementia. Okay. So you have with activity levels with delirium, you're going to have things like restlessness, sundowning, sleep disturbances, whereas in dementia you just may have sundowning. Your emotional state is going to be a little different. With delirium, you're going to have rapid mood swings, aggressiveness, fearfulness, anxiety, being paranoid or suspicious of others. You're going to have hallucinations and delusions. Whereas with dementia, you're just going to have a very flat affect and you may be a little delusional. With your delirium in dementia, your speech is going to sound a little different. With delirium, you're going to have rambling. It's going to be inappropriate, rapid, and incoherent. Whereas in dementia, slow and incoherent, repetitious and inappropriate. So, little different. And the biggest difference as well is the prognosis. Delirium can typically be fixed or reversed as long as interventions are placed, whereas dementia, there is no cure, there is no fix. There are some things we can do to halt its progression, which we'll talk about that with medications, but in the end, it's just going to deteriorate. All right, so now we're going to talk about some of the different domains of cognition. We have complex attention, executive function, learning and memory, language, perceptual motor, and social cognitions. So starting with complex attention, this is going to be things like our sustained attention, divided attention, selective attention, and processing speed. So processing speed is how long it takes you to complete the task that needs your attention. Selective attention is like the ability to count the letters while hearing other things in the background, hearing other numbers and letters. So being able to just focus on what you're doing while things are happening in the background. Divided attention is where you can tap on something or tap your fingers, tap your toes while listening to a story. You can do two things at once. Sorry about that. Do two things at once, and sustained attention is being able to follow commands. Press this when this is heard. Okay. So major issues within this is going to be things like difficulty in environments with multiple stimuli, being easily distracted, and needing simple and restricted input, and thinking and the processing is going to be slowed, and thinking is going to take a lot longer. Whereas when we have mild issues with attention, we're going to have our tasks are going to take longer. We may need a little bit more double checking because they can get a little distracted, and they can think better without distractions, but it doesn't prevent them from doing it. Okay. We have our executive function, which is planning, decision making, feedback, working memory, mental flexibility, and overriding habits. So our planning is going to be our ability to interpret a sequential picture or object arrangement, or be able to find an exit. Decision making is going to be picking between two things, making a decision. Responding to feedback is going to be inferring rules from problem solving. To kind of think back to that elementary school math class that you did, you had to find the rule, things like that. And then mental flexibility is going to be shifting between two tasks, concepts, things like that. And then overriding habits is going to be the ability to name a color that a word is written in versus the word itself. Okay. Um, Major issues with executive function: stops complex projects altogether, focuses on one task at a time, there is no multitasking, and others are going to have to make decisions and plan for them. So autonomy is usually a difficult ethical dilemma with some of these individuals because they truly cannot make their own decision. And then mild, we're going to have more effort. There's going to be more effort needed in completing multi-stage projects, and we're going to have a difficult time multitasking, but it's not going to be impossible. Okay. So then we have our learning and memory. This is immediate, recent, and long-term recall. So major issues that you're going to repeat yourself in conversations because they cannot keep track of a short list of items. And they can't remember things that they've said, things like that. With mild, they're just going to have difficulty recalling recent events and they're going to need reminders. Um, Normally, in neurocognitive disorders, our recent memory is usually what gets deteriorated, not our long-term memory. So we can remember things from way back when, but can't remember what we ate for breakfast. We can now have issues with language, which can be expressive, grammar, or receptive. So expressive is going to be identifying objects, pictures, words, things like that. Receptive is going to be comprehension and performing a task. And then grammar, there could be a lot of issues with grammar. When someone has a mild issue, they're going to have difficulty finding words, like remembering what the words are, and they may substitute general names for an acquaintance. So instead of saying Barb, my next door neighbor, you might just say my neighbor, because you can't remember their name. And they're going to have subtle grammar issues. During major issues, we're going to have significant difficulties expressing language. And we're going to use pronouns rather than names and use general words. So instead of saying my neighbor, instead of Barb, we're now going to say her over there, the woman over there, because we can't even remember the word neighbor. That thing instead of the microwave, things like that. Okay. So now we have perceptual motor. So we have visual perception, visual constructional, perceptual motor, praxia, and gnosia. So visual perception is facial recognition. I suck at that. Visual constructions, drawing, copying, block assembly, things like that. Perceptual motor is going to be inserting blocks into a foam, into the form, into a form without any kind of help. Praxis is imitating gestures or learned movements. And gnosis is requisition of faces and colors. So when we have mild perceptual motor issues, we're going to rely on maps and other people for directions. We're going to use notes. They're going to frequently be lost if not concentrating. We're going to have less precise parking and greater effort for tasks. Whereas with major, we're going to have significant difficulties with familiar activities and environments. And we're going to be more confused at nighttime, which is at sundowning. Okay. So now we have social cognition, which is recognizing emotions. So of being able to, when I'm crying, being able to understand that I'm sad. Excuse me. For mild, we're going to have subtle behavioral and attitude changes. We're going to have a decrease in empathy and inhibition and restlessness. Major issues, we're going to be insensitivity to social standards of modesty and topics of conversation, and they're going to be making unsafe decisions. So those are just different pieces of the puzzle. Biggest things that I want you to pull away from this is what these things should look like in someone without neurocognitive issues, and what it's going to look like with someone with neurocognitive issues. So kind of what is that going to look like in somebody? All right, so this one we're going to talk about Alzheimer's disease and the different stages, things like that. And I'm going to talk about some words that I want you to know. So we have mild stages of Alzheimer's disease. So this is the beginning stages. During this time, the client is going to still be fairly independent. They're going to engage, they're going to drive, they're going to perform ADLs. The client may misplace things, forget appointments, but things are not obvious. It's just chalked up to everyday issues. And typically the first people who notice it are going to be close family and friends, things like that. Okay. So during this time, clients are going to create new nonsensical words called neologisms. Neologisms. So this is calling new words for something else. I hope y'all have all seen The Little Mermaid. This is, she doesn't know what a fork is, so she calls it a dingle hopper. So that's kind of what neologisms are. And we're going to talk about that again when we talk about other psychiatric disorders. So remember that word. We're going to have deficits in language. And we're going to have memory deficits. So kind of thinking back to what we just talked about, we're going to be in those mild stages of that. During this time, we want to maintain healthy behaviors. And this is a good time to make end-of-life choices because they can think during this time and they can make decisions during this time. Once we get out of this area, it's going to become more difficult. Okay. Next, we move to moderate stages. So during this stage, they're going to need more and more help from others. They're going to get very confused, very frustrated, and angry and irritable. The client may have issues expressing thoughts and performing tasks without help. Okay. So some manifestations during this time is going to be forgetting events or personal history, forgetting your wedding date, forgetting your daughter's wedding, forgetting your birthday, things like that. Being withdrawn or having a libel mood, meaning you're moody, you're kind of up and down. You're going to have trouble recalling information. You're going to be confused about time and location. You'll probably need help getting dressed for an occasion or season. So they may be trying to wear a snowsuit in the middle of July. We're going to have disrupted sleep issues and have a tendency to wander or become lost. This is huge. During this stage, we see a lot of patients who leave their environment at night wandering, and they get lost. My great-grandfather lived in Louisa, and he was in the stage of Alzheimer's, and they did not care for Alzheimer's disease like they do now. And he was able to unlock his door, go outside, and wander into the wilderness, and he was out there lost for 4 days. So a big one that we're going to talk about is locks and high up locks that are in abnormal places, so they can't just open the door and go out. Okay. And then we're also going to have behavioral issues and loss of bowel and bladder control. Okay. So some words that you may see coming up in this stage that I want you to understand is sundowning. A lot of y'all have probably talked about this before. Y'all probably saw it in funds when you were in the nursing home getting ready to leave. This is when manifestations get worse at night. When the sun goes down, the crazy comes out. Perseverate. This is where we're going to make repetitive verbalizations or motions due to neurocognitive issues. So it's going to be like repetitive motions or words. Confabulate is a big one. This is creating a fabricated story or distorted memories when you can't remember something. You asked your patient what they did last night, and they told you that they went to the moon with Neil Armstrong because they really don't know what they did last night, so they're making up something. We have aphasia, which is the inability to remember or use words correctly. I know y'all talked about that a little bit in funds. Apraxia, which is the inability to perform motor tasks, even though the physical ability remains intact. So this might be them not being able to tie their shoes. Their hands work, they can tie their shoes, but they don't remember how. And then agnosia, which is the inability to recognize objects, even though sensory ability is intact. Okay. And then we move into severe Alzheimer's disease. During this stage, client's going to have many cognitive losses and will need help with lots of ADLs. Clients are going to have difficulty communicating, responding and reacting to their environment, and controlling their movements. Behaviors are usually not consistent with their personality, such as hostility, when they're normally a easy go with the flow kind of person. And some other words that I want you to know for this stage is agraphia. That is the inability to read or write. Hypermetamorphosis. That's the feeling the need to touch everything. Hyper or orality, which is putting everything in your mouth, and things like that. And ataxia, which is lack of balance, coordination, and speech. Okay. So during this time, nurses may need to offer caregivers respite care and resources and palliative care resources. So, of course, respite care is giving family members a break while the client is supervised by a professional caregiver. Um, we used to, we, um, I used to have a friend who was a respite caregiver in the foster care system. She would not take in foster kiddos of her own. She was pretty much an emergency hotline. If the kiddo was having a super hard time, the parents really needed a break, or even they had a planned vacation that the kiddo can't go on, they would go to my friend's house for respite care. Um, you also have your other family members can be a source of respite care as well, but typically this is a professional person providing respite care. And then, of course, we have palliative care, which is medical care focused on comfort and symptom reduction with life-threatening illnesses. And of course, Alzheimer's disease is continuous, so does qualify for palliative care. So pretty much things that you've already seen before, just kind of going into a little deeper. And we're going to go over these words again in class. So don't fret, but I just want you to kind of be able to recognize them. Okay. So let's talk about causes, epidemiology, and etiology. So delirium can be caused by a variety of acute physiological changes in the body. This can be substance use or withdrawal. It can also be dehydration, electrolyte imbalances, infections. Remember, I know y'all talked about this in funds. Old lady is in the nursing home and she all of a sudden gets confused. What's the first thing we're checking? Urine for a UTI. Hepatic encephalopathy and other things like head trauma, tumors, pressing on certain parts of the brain, metabolic issues such as thyroid issues, and B12 deficiencies. Okay. We can have frontal lobe degeneration. So frontotemporal lobar degeneration just means degeneration to the frontal and temporal lobes of the brain, which I know y'all talked about in anatomy and physiology. These areas of the brain are used for safety, but decision making, logic, things like that, and language. So when the frontal temporal lobes are affected, we're going to have behavioral issues. We're going to have clients performing more riskier behaviors, and we're going to have issues with language. Okay. We have vascular disease dementia. So this is, of course, going to come from vascular issues. We can have Lewy body dementia, which is going to be Parkinson's effects, like rigidity, tremor, shuffling gait, bradykinesia, and Alzheimer's disease, such as memory loss, confusion, issues with cognition, and hallucinations, delusions, and depressions. Okay. We have traumatic brain injuries. So this is going to be dementia that is caused by a TBI, a traumatic brain injury. This is damage to the brain. It could be things like, you hit your head too hard. Some comorbidities of this is going to be other injuries from the TBI. So if you're in a car accident and you hit your head real hard, you have traumatic brain injury dementia. And then you also have a broken arm from the crash. We have substance and medication use dementia. So frequently used substances known to cause dementia later on down the road. Alcohol, inhalants, sedatives, hypnotics, analytics, amphetamines, and cocaine, Jesus. Um, so a big thing that we see, so we already talked about how delirium can be caused by drug overdose or drug withdrawal. Substance use dementia is long-term effects. So they've developed dementia later in their life from a past history of drug use. So a little different than substance use delirium. Okay. We have HIV infection dementia. So this is a client who has a neurocognitive disorder and also has HIV, and is more prevalent in those who have high viral loads of HIV. During this time, the HIV, that virus is now attacking your brain along with other organs in your body. We have Parkinson's disease dementia. So we talked about this. I know y'all talked about this a little bit in pharmacology when you talked about carbidopa, levodopa, and all of that. So all that stuff is going to come back round table for us. Clients who have this type of dementia have Parkinson's disease, and this is going to be those tremors, rigidity, slow movement called bradykinesia, postural instability, dystonia, and gait problems. And we have Huntington's disease dementia. So Huntington's disease, as it progresses, clients are going to see things like impaired gait, impulsive behaviors, memory and cognitive impairments, and the client is going to need more help with ADLs. So this is brain damage, signs of dementia, but the root cause is going to be, that's what I'm thinking about, is going to be the Huntington's disease. Okay. So pretty much all of these right here, it's all the same thing. It's still dementia, but what is the cause? Is it frontal lobe damage, vascular damage, traumatic brain injury, substance use, HIV, Parks, or Huntington's? So it's just all the same thing, but the root of why is what makes these different. Okay. So some ways to reduce the risk. Things like wearing helmets when on bikes and motorcycles to prevent head injuries, using seat belts in cars to prevent head injuries, practicing safe sex and avoiding used needle use to reduce HIV, and learning new skills while aging to reduce vascular and Alzheimer's risk. And also we may want to get genetic testing for Huntington's disease to reduce the risk of having a child with Huntington's. So those are just some ways we can prevent it. Now let's talk about clinical presentation. So consistent routines are important for clients who have dementia. Again, we want consistency. We want constant caregivers, so the same people assigned. We want people who understand the need for a calm and non-overstimulating environment. We want to use things like seasonal decorations, calendars, and clocks to kind of help keep them adjusted to time. Okay, so manifestations are going to start become noted. So when you start noticing grandpa's putting his keys in the freezer and thinks it's Christmas and it's Easter, doesn't really understand who, what, when, where, why, we'll take them to the provider, and typically some tests will be looked at. They'll look at things like lab studies, like vitamin levels, electrolytes, thyroid function, CAT scans and MRIs, glucose, drug levels, liver kidney function, CBC, And then we may also look at EKGs. So we're kind of going to look for if there's any underlying root cause for any of these behaviors. When a client presents with delirium and they do not have a history of dementia, we want to look for the cause. And we've kind of talked about this: substance use, dehydration, infection, hypoxemia, things like that. Okay. So then there are a couple of different tests that we can administer, or assessments, to see where they are. So we have the mini mental status exam, which is going to look at different stages of disease or dementia. So stage 1, we're going to have slight short-term memory and visual impairments, difficulty finding words, glucose metabolism is going to be slowed. We're going to have impairment of smell and blood flow to certain parts of the brain. And clients are going to function well, but can easily decompensate. In stage 2, we're going to have more severe short-term loss, memory affecting ADLs, trouble speaking and doing calculations, and struggling to translate thought into motion. They may be apathetic, and EEG will slowing of brain function. And then in stage 3, we're going to have intellectual function is going to be severely degraded. Frontal lobe may be the last to experience loss. Rigidity of muscles and limbs, abnormal MRIs, things like that. Okay. And then we have the functional assessment stage, which is a stage 1 through 8. And it kind of looks to see if you have normal adult, normal aging, potential to have Alzheimer's disease, mild, moderate, moderately severe, severe, and severe terminal. So it's different stages. So that's just another test we can do. Okay. So we kind of talked about this earlier. Delirium, very rapid onset, typically has some form of contributing factor to homeostasis, like head injury, drug reaction, withdrawal, fever, infection, hypoglycemia, dehydration, things like that. Level of consciousness is altered. Our activity levels are going to vary, and the prognosis is that it's going to be reversed with interventions. Dementia is going to be month to year onset, so it's going to be a slow process. Alzheimer's disease, vascular disease, HIV infection, chronic substance use are all going to be contributing factors. In dementia, your level of consciousness is not altered. They may have flat affect and be delusional. Their speech is going to be slow and incoherent. And of course, it's going to progress and worsen. They're not going to get better. Another thing that the early symptoms kind of look at, so we have delirium, we have dementia, we also have depression, which we talk about later in the semester. But that's going to be a gradual with exacerbations during stressful times, because sometimes the signs and symptoms of depression can look like dementia and a little bit. So we want to make sure we are differentiating the two, because treatment is going to be different. Once again, because we can have things like forgetfulness, inattention, difficulty concentrating. Once again, level of consciousness is not altered. We're going to have decreased activity, fatigue, poor sleep, lethargy, and lack of motivation. And then, of course, our treatment for this is medication and psychotherapy to help. So this one does have ways to help it get better. All right, so now we're going to look at the role of the nurse and some interventions that we can do. So the nurse needs to provide care focused on the current needs of the patient and their stage of decline and individual issues. Early on, reminiscence therapy is very beneficial. That's something I'm going to want y'all to know. This is kind of where we talk about we can make scrapbooks, legacy books, record important events, kind of help them remember a visual aid to help them remember when their mind can't help them anymore. This therapy will help improve self-esteem, and clients will be able to see what they have accomplished during their lives. So this is very helpful. Okay. We have the mind diet, and which is Mediterranean dash intervention for neurocognitive delay. And then, so with that, that's going to be a healthy diet of fish, vegetables, plant oils. Exercise may slow the progression of Alzheimer's. Omega-3 fatty acids that are found in fish, flaxseed oil, nuts, leafy vegetables have been shown to help with the cardiovascular system, including the brain. The MIND diet combines that Mediterranean diet with the DASH diet. DASH we talk about when we talk about geriatrics, but it is the dietary approach to stop hypertension. So, that's your low fat, low salt, low sodium diets, things like that. And this is shown to be effective in promoting cognitive function. Okay. So then, of course, we are responsible for making sure that the client is in the least restrictive but safest environment. And if a nurse feels that a client is not in a safe environment, a report to Adult Protective Services is needed. Okay. So safety interventions for a client at home who has dementia. We definitely want to make sure supervision appropriate to the stage of illness. Medication adherence. Placing the bed mattress on the floor to prevent falling. Make sure they know how to contact important people like spouses, children, EMS, if they are at a point where they can be alone. Educate family on the disease and importance of monitoring the needs of the client. Making sure nutrition and hydration statuses are maintained. A lot of times our people with dementia, they forget to eat or drink, so we have to help them with that. We want to ensure hot water and oven safety because they may not remember how to use these things and can hurt themselves. Permit elopement risk by placing tracking devices on the client. Things like they have those bracelets and things also like we talked about locks higher on the windows and doors. Notify law enforcement as needed to monitor the chance of wandering. Remove smoking materials. Evaluate house for standard safety issues such as poorly placed furniture and throw rugs. Minimize sensory stimulation. Install rails in the hallways. Remove sharp objects, and restrict or forbid the use of a car and arrange transportation as needed. We also talk about labeling rooms and drawers to help them know where things are, to help keep them as independent as possible. Consider mail delivery. Encourage activities the client can still do. Yeah. So those are just different things we can do to keep them safe. When we talk about managing delirium, there are many different causes for the symptoms, which we've already talked about. We must analyze the client's symptoms that are associated, review the body systems, and find the underlying biological cause of this. And then we can kind of help promote what is needed. If it's malnutrition, we can restore fluids, electrolytes, protein, other nutritional issues. If it's an infection, we can initiate our antibiotics. If it's medication induced, we can discontinue the medication. If it's hypoglycemia, we can monitor and restore blood glucose. So there are different things that we're going to do for delirium, but the biggest thing is understanding the why behind it. Because if we don't know, if our client is going through withdrawals, but we think it's malnutrition, giving them electrolytes isn't going to help. So we need to figure out the why and treat the why. That's how we fix delirium. So now looking at the nursing process, as y'all know, this is still your ad pie, which I have added beside kind of what we're doing. But there's some new words that have been added to the clinical judgment model. So I want y'all to understand those as well, which is recognizing, hypothesizing, generating solutions, taking action, and evaluate. You're going to see these over and over again as you guys are taking the new NCLEX. We want y'all to be more equipped to understand the situation around you, not just regurgitate information. So assessment of clients who have neurocognitive disorders is going to include cognitive and perception disturbances. So we're going to look at hallucinations, delusions, confabulations. We're going to assess their physical needs, so their ability to care for themselves, their moods and behaviors, such as hostility and depression. In clients who have delirium, we want to alert for manifestations of irritability, confusion, hyperactivity, trembling, tachycardia, tremors, nausea, vomiting, seizures, and hallucinations. After we identify what the client is going through in the assessment, we need to analyze what's happening with these assessment findings. So the biggest one is going to be, is the client safe in their environment? The nurse will need to determine if the client is safe at home, in a daycare situation, or with a designed caregiver, or if they need a facility that specializes in memory care or substance use withdrawal. Clients who have delirium or dementia are usually cognitively impaired. We need to make sure that we analyze and prioritize care. And of course, we want to prioritize safety. Clients who have substance use disordered may need to be monitored for in a detox facility where they can safely be withdrawn from substances. Clients with dementia may need to be placed in facilities with 24-hour supervision if they frequently wander from home or do not have supervision at home. We need to analyze the stage of the disease and make sure we tell the healthcare team what's going on so that they can treat for where their current needs are. And then in the early stages, we need to make sure that the client is very involved in their family therapy, or in their planning and things like that. And we also want to make sure we're providing caregiver support. We talked about that earlier with the respite care and education, things like that. Regardless of if a patient is living at home with supervision in a full-time facility or part-time facility, our interventions that we are going to plan are going to be non-pharmacological and pharmacological. Of course, the pharmaceuticals we talked about, they do not cure dementia, but they can extend the earlier stages to give them more comfort so they can slow the progression. So non-pharmacological medication management is going to be things like mobility, families in care, restricting the use of analgesics and sedatives, preventing and treating delirium. And we want to make sure that we are doing things like proper nutrition, hydration, and daily exercise. Medications, I know y'all talked about this in pharm. One of them is your cholinesterase inhibitors. This is our donepezil. And we also may combine metamine hydrochloride with it. So those are just some meds. Donepezil is one I see come up on ATI a lot. So just want to make sure y'all remember that drug from last semester. Then, of course, we're going to evaluate clients frequently as their manifestations and safety needs can change because they can progress into different stages. We need to make sure that we're evaluating caregiver stress, caregiver fatigue, and providing that respite care as needed. We need to plan discharge from facility or setting of care by assessing the current client situation and prioritizing safety. And we want to make sure that we have a good medication routine and that they are, again, maintaining safety. Of course, we want to monitor and reassess the situation as the plan may need to be revised. Y'all know this, that's your ADPI, but this is just applying it to someone with neurocognitive issues. Okay? You guys got this. I know y'all do. Just keep going. Y'all got this.